You're moving synovial fluid, you're relaxing the person, it's a soothing effect. It will deactivate a lot of irritation, reduce a little bit of swelling and some of the pain patterns as well. Again, if you just go into a little bit of abduction, again, if you want to make it interesting, put a little bit of internal rotation, because we know that before, or even a bit of external rotation. Just playing around like that can form the basis of all the mobilization you do with somebody in grade 3 plus or 4. Somebody who's pre-surgery. This is pre-rehabilitation. It will have a massive bearing on how well they go through the post-op and the rehabilitation phase after the replacement.
So before and after?
Yeah.
It goes really well in a myofascial sense as well.
Oh yeah, absolutely. Again, the exact same technique. Just if you can just put a leg across the bed, like that you're looking in, grab and hold the femur, and just lean back. Again, put a little bit of external, a little bit of internal rotation, and it's traction and compression, exact same as the other technique, and just a variance on the position. Again, like a little harmonic. Okay. Everyone already has the fascial roll, and you can get them if they're, grade 1, 2, definitely, maybe 3. Can I get you to externally rotate your ankle? And I match, and let's relax, deep breath in, deep breath out, and I just stand up forward and roll in.
What's that called, you say?
It's a TFL fascial release.
So we do it again from the beginning.
Never, just here. We'll do it again. So, again, one hand in, and again, you need to squat down, get this arm as far as you can, roll the leg, and then you stand up. Okay, you would have covered this like a break and stick and that sort of thing.
We did the break and stick, we did that on the side.
Yeah. So, okay. And again, that's it. Or you can go to the next level if the person's young and healthy enough, externally rotate your foot. Yeah, let's relax. Just take it up again.
So that's like kind of MET type finisher for it.
And you're getting him to
External.
rotate.
Yes, yeah, absolutely.
So you scoop in under the thigh, internally rotate.
No, it is. It's very nice to get done. Absolutely. And it can be quite powerful in that as well. Working to follow up from the positive finding here, you can do transverse friction locally. A bit of an exposed, compromised position. You'll find this one is better, the favourite position. But the secret is, you put their tummy against, their knee against your tummy, and you let them know that it's not going to fall off and they're not going to get jerking, jagging, groin pain. So you say, knee is safe here. And you just move up here if that's all right with you. So invasive region.
That's your friction, is it?
It's knife hand that they often call it. So you just put your fingers in there like that. It can be turned into a friction, but you're just letting the fascia unravel around your fingers.
So that's you're just in the groin area.
Yeah.
And you just literally put pressure through.
Yes, and avoiding that working directly onto the pulse.
And you're going into the acetatum there.
That's what we're going to next. If somebody has a lot of jaggy pain on that, the next one is going to be literally trying to put your fingers into the acetabulum. And it's as much fun to have it done as it sounds. So, just sorry, let's just put you back there. And then just fire it. Funny there already. So again, I'm just going to working with the person. If this is too slow, hey, time to stop and move back off. So now we have it. Very strong technique, not suitable for everyone. And then move back in. And he's just starting to say, thanks for the cheers, that's all working and going again. But you see him twice a week because of it. So you can work with the client, again, lower sins, so grades 1 and 2, or some sort of dysfunction on compression there.
Charlie, can you just run through that again, just maybe
No.
No, not
I won't
the
go through it.
positions, yeah, not the treatment.
So again, you have to identify basically the femoral neck, the acetabulum, and where the femur's going into it. You're literally trying to put your fingers into the acetabulum.
Have you a way of finding that, Cheryl?
Yeah. There it is. So like your compression test we did a moment ago, that's going to show you exactly where you need to be. Your palpation on the line, on the ligaments, and you identify it quite, you will. And then you're trying to keep your fingers here, just let your knee bend, knee bend, knee bend, and he doesn't know what I'm going to do. Ah, he does now. Ah, just let you relax there.
So you're just sitting your fingers into the area and just letting everything relax?
At the basic level, yes, but I really am trying to get my fingers into the acid pattern.
But you're not actually doing anything, not that you're not doing anything, you're not moving your fingers, it's just...
Oh, yes, yeah. Microscopically, you are teasing through, yeah. Or you can just wait.
But you're bringing the leg into a bit of flexion when you're doing it.
And
So you're starting in the kind of Fabers position again,
Yeah.
and then
That exposes
you're-
it the most.
you're-
That's pulling the hip out as much as possible.
Okay, and then you put, without doing, you're just using your body, your
Yeah,
arm around
just
the
a
knee to kind of bring it
Yeah.
into flexion.
Yeah.
Okay. And did you say then you could do internal rotation as well, or is it just flexion is the movement?
Oh, no, no, definitely.
But you don't have to.
No, I won't do it, I won't do it strong. So I'm on the point,
Yeah.
I've got the flexion,
Okay.
I'm just trying to get him to relax. 'Cause there's a
Okay.
bit of-
So you're
and
internally.
the ligaments are fighting me.
Okay.
So,
Okay.
and then you go in like that. Now, nicely.
Okay. Okay. So.
How's that feel for you?
Oh, that's hard stuff. Now, that's hardcore. You would love that one.
Elbow.
So what's to do?
Elbow me.
I'm not sure.
What's the benefits of that, Charlie? What's the benefits of that?
If you get to
Nourishment
some,
into the joint, or?
no, decompressing it, relaxing the intrinsic structures.
Okay.
So there's shortening and contractures forming in the ligaments because of the tight soles over time and the rec fem.
So you're decompressing.
You're just letting all the tissues normalise, and you can and that will of course have a knock-on effect, letting the ligaments move slowly and fluid, and let the hip articulate correctly in the joint.
Who would that be suitable for, that kind of treatment?
Grades 1 and 2 are somebody that's a bit tender on that. Grade 3, very carefully. Very low grade 3, grade 3 plus 4, no. Okay. So again, working on the same technique from a different angle. Again, lesion inguinal ligament, your ulnar border. And again, just looking around. Again, if you're small and you're trying to think, you don't be wrecking your fingers. And you just, we're not on it, but we're very narrow there we are. And then supination
And
pronation.
you're on the joint again then?
Yeah, you are. Can I get you to turn the external rotate your leg?
Are you hitting a bit of psoas there?
Everything that can cross the joint, yeah. Yeah, very much so. It's very, so that's really decompressing technique. Okay. So that's a nice one, but they're doing the majority.
Kind of on that inguinal
Yes,
line out with you.
absolutely. And it's a broad context, so it's not as jerky or as piercing as the other one, but they're working the fascia. They're doing the sawing action of the new doing it. Okay, now one more. So this is pure mulligan. So, if you've identified a pinch or grinding on this, the scour test reproduces it excessively, the traction reduces it. You really want to decompress that region. The techniques we've done up to now are absolutely perfect for it. But if you want to mobilise the joint, use a towel or a pillow. And you can practice without it and get it done to you without it, and you'll see why you use it. The adductors hate this, so this is what that's for. Again, so just let you relax there. So it's a little bit tricky. If you're filming, you try and get an idea of this. I'm bringing my ulnar border right up to as close to the joint as possible. My other arm is reinforcing it. I've started in a low position because I want to go up like that, causing an abduction at the joint. Okay, and then just mobilise like that. And then if you want to put a bit of internal, external rotation in it, same thing.
And what you're doing there is trying to
I'm
get the
pulling my
femoral
arms
head
towards
out.
my tummy,
Yeah.
cause that.
You're pulling your arms
Yeah.
towards the tummy.
And then,
So it's traction as well, but it's lateral.
exactly, yes.
Somebody's tightening the adductors, that's...
Yeah, my pressure's on the adductors, so if you don't have a compression, like a towel or something soft there, it's quite unpleasant.
What are you mainly releasing there? What are you targeting there? The
You're
glutes, TFL?
abducting, you're trying to pull the femoral neck out. That's going to cause a stretch in the ligament. It's going to move the synovial fluid. it's going to relax the the local intrinsic muscles, those short muscles across that joint. Okay? And then if you put internal and external rotation, you can focus on the different ones. Okay. Yeah. Back to you in 1 second.
Your grandfather.
2 minutes.
400 things there.
So,
Oh, they're in there. Once they're in, they're in.
Well, that's not moving.
Now, when you're doing this technique, the first thing, if you're working on men, you make sure everything's out of the way.
Dressed for men, something very
So, again, you have to go on this side to sort of see the positions. Now, so that's the same technique. I took the, you should use a towel or something like that here, just that you appreciate the hand position. That's what we're doing, and you can see the bite of the into the adductors. Can I get you to bring your knee to your chest? So he's doing the work. I'm just pulling, my left hand is on the iliac crest, my right hand is not letting the leg come external here, so I'm literally trying to pull the femur lateral, but he's doing an active range of motion.
So are you putting any pressure on your hands? Or are they just...
Moderate. Like I'm just...
So it's at the knee, is it? Is that
Yeah, and the other one at the iliac crest.
Yeah. I'll just cross.
Yeah, there should be, I'll do it the right way then. Just let you see what things are doing. That's grand. Just make sure everything clear. But again, a small person is working a larger person because it's active. He's doing the movement.
And when one for very specific kind of clientele.
Grades 3 plus. High irritation. And again, undiagnosed problem.
The prominent business.
Okay. Now, I'm going to lie onto your side this that way. So you're going to talk through this one. I'll show you.
It's a shame he's got nothing on this, but it's on 60.
So I got the whole lot.
that's really intimidating.
Got a load of ideas now going home.
I'm very open to bribes.
We have somebody with trochanteric bursitis. So we'll do it with 3 of those. So, what you're going to do is try and find something, an activity to reproduce his pain. So stepping up, stepping down can be quite an effective one. So again, so there's your trochanter. Your test, it's usually the posterior aspect of the trochanter. Have you pain here? Oh, that's my familiar pain. It doesn't, as with the other olecranon and the other bursitis, doesn't show heat clearly. It doesn't show redness, doesn't show swelling because of the endothelial band. But if you put this on anteriorly, pinch it down and draw the tissues back and reposition it. Now, it doesn't hardly tear them. Reposition it. You pull the TFL over into a different position onto the trochanter. Get them to do their activity that will reproduce the symptoms. See if that changes it. If it does, you leave it on. However, if it doesn't, same thing, you stick it on, traction everything forward, put into the different position, pulling everything forward of the trochanter, and then get them to do their activity. If that reproduces it, that's the way you leave it. In conjunction with your breaking the stick, your fascial unwinding, and particularly this release here.
So when you do that tape, you're obviously using it as like a treatment but are you going to, I don't know, like put tape on them like before they go home, or you just, okay.
So same rules with all the tape. You do some taping, don't you?
Yeah, we do tape, we don't really only for sports.
Okay, we will be doing taping for feet, tie-dye and a few other techniques. So, zinc oxide tape, that's a pretty good thickness to